Hey, how are you, Jason?
Good. How are you doing?
Chair sits low. Someone might have.
I've been waiting to just like do the turn side to side. Thanks for joining us on stage. Tell us a little bit about, I think I have a slide here actually. Tell us a little bit about OhioHealth and the, did I go back? And the capacity challenges you had. What were you looking to solve when you came looking for us?
Yeah, so OhioHealth, we are 16 hospitals, 35,000 associates and providers. As you can see, all of the other stats up here, we're a relatively large health system in Ohio. We span in about 53 of the 88 counties in Ohio. So we have a nice network across the board. We do have a central focus in central Ohio in the Columbus area, but we go all the way out towards the Indiana border, all the way down towards the southeastern side of Ohio. I think like every other hospital that I've talked to in health system, we were having a hard time moving patients out. And as a high reliability organization, I think we understand the importance of process and standard work and how that really plays into driving efficiency across the board. And we were muscling throughput through. It took a lot of people, and COVID really highlighted that for us. And I think through that work, we identified, hey, things like estimated discharge date, there are understanding discharge barriers and milestones and all of the things that we need to do to get a patient out. We understood the importance of it. And we had a central focus of moving patients, and we were relatively successful. But then, COVID ends, and your focus shifts again into the broader business of everything else. And we were really struggling to move patients, and it manifested itself really in our emergency departments. In particular, we saw ED boarding times go way up. We saw length of stay go up, PACU holds go up. And so those were all those indicators to us that we aren't moving patients out on the back end.
Yeah, and it's not as though you weren't doing anything to tackle these problems. In fact, you all, like Walt was sharing kind of this circuitous route that IUH had to Qventus. Like you all had kind of a similar kind of experience, because we had talked to you back in 2021, 2020, something like that, and you decided to go a different path at first. Can you talk about that? Yeah,
sure. So we actually took a unique approach in about 2018, 2019 timeframe, and we created what we called a fusion team. I had the opportunity to lead that team, and the central focus was, Scott, go build a team of people that are only going to solve one problem, and that problem's going to be throughput. And we're like, oh, that's easy. Yeah, let's do this. And so we were gung-ho, but we did a lot of deep learning, and we went, and that's where we learned, hey, you need to make sure your data is transparent, it's out there so people can use it, you need to be talking to it, and then you need to let that data really drive your strategies, and that's where we landed on things like, hey, setting what I called the shot clock, EDD, was going to be really important. And having our providers own that was going to be really important to that process. And bringing the care teams together to have a similar conversation. And then identifying what are the barriers to getting these patients out so we can actually break them down. And so what we were seeing is it's inconsistent, right? It's provider dependent, it's care manager dependent, it's nursing unit dependent. So you see your high performers, you see your lower performers, and we just had all of this variability we couldn't keep up with.
And what were some of the initial things you tried? Because I think we had those initial conversations back again many years ago, and you all decided to pursue, you tried to maximize what investment you'd made in the EHR.
We leaned into Epic. We're an Epic shop. We've been an Epic shop for about 11, 12 years now. So we leaned into them. And as we were talking to Qventus at the time, you weren't integrated into Epic. And that was really kind of our deal breaker at that time. And so we partnered with Epic. We had a boost resource. We built, 19 dashboards. We created an entirely new department, which we call the System Capacity and Resource Center. And we staff that 7 days a week with our quote unquote air traffic controllers or our patient flow coordinators. And they're truly our experts in patient flow. And they're the ones that were overseeing on a broad scale, where's our capacity, where's our constraints, what hotspots do we have, and from a barriers perspective, are there themes that we should be addressing as a system? Because we knew if we can approach certain problems as a system, our likelihood of solving them went up, rather than care site to care site trying to solve these smaller micro problems.
Yeah. And then fast forward a couple of years,
Yeah.
you give us a call and say, hey, we're actually interested in dating. Let's talk about this. And we get engaged and we work together and we deploy a solution.
Yeah.
You all have kind of a unique, what shouldn't be a unique, but probably is more unique approach to that, this kind of people, process, and technology focus that I think not just in terms of our work together, but that you take elsewhere. Can you speak a little bit to that?
Yeah, it was a really intentional, thoughtful approach, I think, that we took. And you know, I don't think that we can take all the credit because this was really based on a lot of the conversations that we had with Qventus, which was, you know, what have you seen successful and what have you not seen successful? And we had already had some work going on where we were focusing on things like multidisciplinary rounds and how do we standardize that. But what accelerated that was the relationship with Qventus. And so as we talk about partnerships, that's what I really loved about the partnership with you guys is we had these Kaizen events where we brought the entire multidisciplinary team together at our 2 care sites where we launched the inpatient solution. And we said, you know, hey, look, we're going to focus on this process. And Qventus came along for the ride with us, right? We had you guys in the room with us, listening to, okay, well, how does your process work? How do we integrate that? And so I really felt like we were developing a solution that was going to really not only meet us in the middle from a process and technology perspective, but also culturally, right? What's the culture of our organization? How do we approach things? And it felt like a co-design that married all of those processes, people, and technology together.
Yeah, I think it felt that way for us as well. And I've heard you talk about this before in terms of the different problems specifically you were looking to solve. So one of them was what you mentioned, that getting care teams aligned on an early EDD. Second one was creating transparency, was really trying to get, you've got all these different ancillary teams, you've got your mission control or your command center, you've got your frontline teams, getting them all on the same page and working together. And then third was becoming more proactive. So trying to turn from this reactive mode that you'd been functioning in, like, oh gosh, we're out of beds, to, okay, we can see that this is gonna happen, what can we do to make sure patient flow is what it should be? Can you talk about each of those problems maybe a little bit, and then also how we were able to partner together to address those?
Yeah, I think what we all know, and this is no secret that I'm going to share, is when our care team is on the same page and we all have the right information in front of us, we're much better. We're much more effective at getting the patients the resources that they need and really moving them through the care continuum efficiently and safely. And I think when we do that well, our outcomes are better, not only from an efficiency finance side, but also from a quality of care. And there's a lot of people that have to come in and be on the same page though, right? And it's not just your providers. You have a lot of ancillary teams that are a part of this. And one of the things that we really loved was how do we prioritize our patients in some of our ancillary departments, and I'll use Echo and MRI as 2 of our examples. They're blind, right? They get a patient list and I've got 30 people and I only got 20 spots. So some, inevitably 10 are going to get bumped till tomorrow. I don't know who needs to be seen first, so it's first in, first out. And what we've been able to do with the work with you all is really to orchestrate, okay, well, this patient, if we get this MRI today or this echo today, we could potentially discharge. And so then it starts to move those patients on the list. And when you talk to these departments, they're like, this is a game changer for us. And it didn't work everywhere either, right? I mean, we struggled to really get lab to do that, and mainly just because of the sheer volume and the number of things they had to do, and it was not really something we were going to overcome. But in areas procedurally like MRI and echo, it made a lot of sense and made a lot of movement for us. And the same thing goes for our multidisciplinary rounds. We're automating the EDD, and while that's great, and again, the shot clock's really important because if I know when the patient should go home, I've got a goal, and kind of gamify that in a way, right? But the other piece of it that's been really tremendously impactful for us is the early disposition identification.
Yeah.
And I think that's really what we were finding was we're now into day 4 of a 5-day stay, and oh, by the way, the patient needs to go to a skilled facility. And now it's working through the pre-auth process. Well, now we're past day 6, we're into day 7, and we could have gotten that process started earlier. And it's that mode of being in a reactive state, right? And so now our teams know on day 1, within 24 hours, Jason's going to probably need home health. Well, let's go ahead and start to work on that, work you towards that as the patient. So we educate you earlier on that, but we also get all the moving parts in place and moving to have that set up for discharge.
I'd love some home health. That sounds great.
Yeah.
And also just speaking to the partnership, I'd say it worked both ways, and I think this is true of a lot of our partnerships. You mentioned MRI and echo. I think about physical therapy, where you have this really thoughtful director of your service line there who recognize that, hey, Qventus is bringing this prioritization algorithm. We're already doing this other thing, that we were able to work with you and be like, oh, that actually is pretty cool. Like that makes sense. Like, how can we actually build this into a single algorithm so that it not only works for the care team, but is getting a better outcome? And so I think we've appreciated it.
Yeah, well, that's a great example of just the give take in the relationship and the partnership. And I think we've gotten a lot of things in both directions. The automation of milestones, not just at our 2 care sites, but we've automated the milestones across every care site. And again, it's not that everybody doesn't know what a barrier or a milestone is in their head, but we might have a different idea. But if we're not talking or it's not in front of us, then we don't have a shared mental model of where this patient needs to go and what needs to happen to them. And so when you're automating these things, now it's getting documented and it's put somewhere for people to be able to see it. And that's really the key. And we couldn't get providers or other folks on the care team to document. It's not because they're bad, it's just they've got a million and one things. And I'm handling the issue in this moment, and trying to document a barrier is not going to be something I'm going to do today.
What are, probably a lot of the people in this room are in the process of implementing an AI technology or solution. What are some of the lessons you've drawn, not just from working with us, but certainly other folks as well, in being successful and successfully deploying a solution that's going to be sustainable, that's going to continue to have support of your, and you call them associates. You don't just call them your staff, they're your associates.
Yeah, one, we have to bring them along in the change, right? Change management is hard, and if you're not bringing your folks along with that change, you're going to struggle with adoption. And I think as we talked about developing the process earlier, along with as we were implementing that, those really married up very well. I think we also take a very thoughtful approach of how we address things like the ROI of this. And we were really intentional to say, how are we going to measure this up front? And we had to come to the table with a very challenging is maybe the wrong word, but I don't have a better one, challenging CFO that's going to be like, hey, I need to see the ROI here. What are you going to do? What are you going to commit to? And we really approached it from an excess days perspective. And we could easily demonstrate that we had plenty of excess days that we could go after and remove. And we knew that in these 2 care sites in particular, we have no problem backfilling those beds. Those beds will get filled immediately. And so we put a line in the sand and we said, we think we can achieve this. And that's what we went out and did. But, working with our care site leaders and having them a part of that work as well, and making sure that they feel comfortable with that commitment is going to be important. I'll use the Grant Medical Center team as an example. I mean, they're crushing this, and they've leaned into this hard though. From, hey, look, we've got this great technology that is insightful, that we should be looking at, and it's right here, easy to use. But we still have to make sure we're adopting and using that information, and they've built it into their management system. And so now that management system is hey, we're going to go to MDRs several times a week. We're going to watch the process, and we're going to coach you on that. And I think any good lean organization should be doing that anyway, right? You have standard work. I'm going to go back and look at that standard work and say, are we doing that? And so those were some of just the ways we think about this as we've gone into this. And I will say what I have heard from our IS team, as well as our operators and other folks, the Qventus go live was the smoothest go live we've ever had of any type of technology deployment. And that says a lot, because we've deployed a lot of technology. Most of the time it's incredibly painful, and this really went very well.
Yeah, I think it's the deposit in the pre-go live work, the assessment, the training. And I know Chelsea's, I'll just like call out Chelsea because she's the one that makes that system hum at Grant. So if folks are interested in learning those lessons, Chelsea's a great resource. As you look to the future, and maybe a little bit more insider than we would normally do on a stage, but like we're talking about a contract right now to expand to peri-op as well as other inpatient sites, but you're not looking to expand to you have a bunch more hospitals.
Yeah.
You're not going to put our inpatient solution in all of them. Why is that? Why does that not make sense everywhere?
Well, and again, I think this speaks to the partnership. We went along that journey of discovery with Qventus, and we did that assessment together. And what I appreciated most about you all and Qventus is that you came back and said, this doesn't necessarily make sense here, right? I mean, this is a relatively non-complex health center, primarily surgical volume. It's kind of rote in the sense of we know what to do, and they don't have a ton of opportunity.
No.
We might not really recommend it here. But we have other care sites that are more complex. And that's really what we went along this journey of trying to say, okay, well, we have this massive EHR tool to our that's advancing as well. And where does that make sense? But also where does a complex center sit in this mix, and how do we think about that? And so, same thing for the peri-op. We have more complex surgical centers that really require a deeper level of analytics, a deeper level of insight and intelligence, so we can really understand the business. And the same thing goes on the inpatient side. In your more complex centers, it just makes more sense.
Yeah. Quick question, the 3 minutes we have left, does that include questions? Do we have to wrap up completely at the end of 3 minutes? Completely. Thanks, Katie. So I have a lot more questions for you, Scott, but I'll stop there and see what questions folks in the audience have. Yeah, Joe.
So with the inpatient solution, I was hoping you could speak a little bit to what culture, good or bad, you inherited coming into the process versus what systemic professional expectation you laid onto, in my bias, the medical teams more so than the nursing teams. But what was that like for you in terms of rounding earlier or engaging with the nurse at the bedside or having dispo planning sessions in a structured way or any of the other things we've seen in the literature that operationalize very difficultly?
Yeah, that's a great question, and thank you for it. What I will say is you have to strike a balance, and that's what we really tried to do between we have this standard, and then we also respect your culture, and we respect your business and your processes that are already in place. And so trying to marry those along the way, right? And so to come in and dictate that, hey, every multidisciplinary round is going to be at 12 noon, and this is going to be the exact things that you talk about, we were not going to be successful like that. But saying, hey, look, we want to understand how your unit runs, and here are the key requirements that we need to meet. Let's talk about how we're going to make those requirements work in this department. And then we're going to document that, we're going to memorialize that, and then we're going to hold you accountable to it. And that's, I think, what a lot of the leadership team, in particular at Grant, is doing, is to say, hey, look, this was the commitment that we went forward with, and we need to make sure that we're holding to that. And we hold everybody accountable. Our vice president of clinical affairs, he goes on rounds just along with nursing, and that's to hold the providers accountable. And the key is everybody plays a role in this, and you can't discount those folks, and you can't let them discount themselves.
No. What other questions folks have? I'll ask you another one, Scott. Yeah. So thinking beyond Qventus, like I think you were sharing what's essentially a lesson for all of us, and that is like don't try to apply the same AI solution across all hospitals in your health system. Like they're going to have different needs, they're going to have different cultures. Other lessons that you would draw, like other general lessons you draw like that, like as you're thinking about like other AI solutions you're looking at. I think you all use Hippocratic, for example, for some stuff. Like as you look at each of those different solution providers, like if you were to advise someone who's never taken on an AI solution, like what are the things to look for? What are the things to beware of?
Yeah, understand your problems. first and foremost. Everybody's going to bring some sexy solution to you and sell you on that, and you're going to be like, yeah, oh yeah, that's a problem. But I think you have to kind of shut yourself off, at least initially, and say, okay, well, what are our problems, what are our opportunities, and then within that, what are the solutions that make the most sense for us? And then you can kind of start to shield, hey, hey, I appreciate what you're doing, I think that's really cool, but that's not necessarily the problem I'm trying to solve today. And maybe it is a problem, but it's not my priority. And you can't do everything, at least we can't. And being able to prioritize what we're going to do is key. So my number one advice is understand your problems and lead with that.
Awesome. Just wanted to give you an opportunity to speak to some of these outcomes too before we end.
Yeah, I mean, they really speak for themselves. But what I would say is, I saw the other excess day savings, and I'm like, oh my gosh, what are they doing? But the 3.5 million, I would say we highly undervalue how we put a value on an excess day. But at the end of the day, it's made a tremendous impact, threefold, I would say, on the investment. And we've seen a 27% reduction in excess days at Grant Medical Center alone. You can see that we've increased our discharge volume. So we are backfilling those beds. So there's a business case to be made from that, right? And we see less patients boarding. Now, we still struggle with the winter surge. And but I will say we struggle with it much less than we had in previous years, and it's just made a tremendous amount of difference.
Awesome.
Yeah.
Thanks so much.
I want one more thing, because
Yeah.
I have to call this out, and I told her I would too. The other piece of this is the analytics that we get, and I just have to say, I can pick up the phone and call Shweta at any time, or my team does, and say, hey, I'm thinking about this in this way. Can you help me figure out how to measure that? Or what does that look like? We talked about our weekend flow, and I'm sure we're not the only place that is not 24/7 really. And so, it's a level of analysis that we've been able to do with this team to understand our problems, and it's been such an amazing resource to have available to us. So kudos to that team and what they provide and bring to us every single day.
Thank you.
Yeah.